So hello everybody, we are going to start with our next section, which is going to be really very nice and informative. And first I would like to invite Mrs. Gandjbakhch, who is going to talk about risk stratification in arrhythmogenic right ventricle cardiomyopathy.
Thank you very much. So I would first want to thank the organization for the very kind invitation. And so I will begin this session on risk stratification on ARVC. So as you know, ARVC is one of the inherited cardiac conditions with the higher risk of ventricular arrhythmia, which are mostly monomorphic sustained VT, ventricular fibrillation, and polymorphic ventricular tachycardia are very rare in ARVC, which is different from other cardiac inherited conditions such as hypertrophic cardiomyopathy or Brugada syndrome. However, the sudden cardiac death is a very major concern in ARVC. This is the main cause of death in young ARVC patients, especially in athletes. And we know that sudden cardiac death and malignant ventricular arrhythmia predominantly occurs between 20 to 40 years of age. And as you see in this curve, it really drops, the risk drops after 40 years. And these sudden cardiac deaths are not always exercise related. So, of course, we want to protect our patients by implanting ICDs, but we know that the risk of ICD-related complication is especially very high in this very active and very young population, and it can be up to 20% at 10 years, especially with endovascular ICDs. Of course, we can discuss subcutaneous ICDs, especially in young patients, and this is usually what I do, but it is not always the best option because you don't have anti-tachycardic pacing, and you can have also some detection problems due to the microvoltage that you can see on the EKG. So you have to stratify the patients in primary prevention, and there are a lot of different risk factors that have been associated with the risk of ventricular arrhythmia in ARVC patients. On this table, you can see that there is some risk factors which are dependent of the patient, from arrhythmias, non-sustained VT, the PVC burden, but also the presence of left or right ventricular dysfunction. But you can see that also genetics have importance in the risk stratification, but also the level of sport activity. You can also see that focusing on malignant life-threatening arrhythmia, there are much less risk factors that have been associated with this specific risk. That includes the young age, male gender, syncope, PVC burden, but also the presence of left ventricular dysfunction and the extension of T-wave inversion. However, to be able to stratify the risk in your patient, you should make a very extensive and full evaluation coming from the symptoms, Holter monitoring, exercise tests. You can discuss to perform an EP study. You need to take into account the results of the morphology, especially of the MRI at the presence of right and left ventricular dysfunction, but also the results of genetics and the level of sport activity in your patient. I would like to focus a little bit in EP study. You know that it is quite controversial if EP study is able to stratify the patient. There are many studies showing, however, that a positive EP study is predictive of ventricular arrhythmia, especially ventricular tachycardia. But also we have to acknowledge that EP study is not that good to predict the risk of sudden cardiac death. In a French study that we performed, 50% of patients that had sudden cardiac death had a negative EP study. And in other registry, especially the Italian registry, the EP study was not at all predictive of sudden cardiac death and fast VTs. So these different risk factors have been taken in account differently in the different guidelines. Here are presented the HRS guidelines, when you can see that the different risk factors were stratified as major and minor risk factors, and depending on how many minor or major risk factors you can find in your patient, you can propose an ICD or not. Sorry.
Just because your ear is happening.
Oh, sorry. Okay? Okay, sorry. In the recent ESC guidelines, they only took in account 4 risk factors: the presence of syncope, the presence of right ventricular or left ventricular dysfunction, or the presence of non-sustained VT, and also the inducibility of monomorphic ventricular tachycardia at the EP study. But we all know that this stratification is not good enough at this time to find which patient should be implanted with an ICD. So there are some effort done in the last year to perform a multi-parametric prediction model by building a score. You know that scores are very popular. And this is the score that has been proposed by the team of Giulia Cadra-Turini. And this score, which was based on a population of more than 500 patients, included 7 risk factors: the sex, the age, the presence of a recent syncope, the presence of non-sustained VT, the PVC burden, but also some ECG factors like T-wave inversion and the right ventricular ejection fraction. And you can see that this score is not that bad, with a good discrimination, with a C index of nearly 0.8 and a very good calibration in this cohort. And you can find this score online on this website. However, there have been some exercise to validate the score in external cohort. Here I presented the result of the French validation that we performed. And what we found is that the discrimination of the score is very good. I think that the risk factors that are included in the score are very probably accurate. But what we found is that this score led to an overestimation of the risk, especially in patients with low and moderate risk prediction. And there were other studies showing the same thing. And what the author found, that there was an error in the initial formula that they corrected, and they published the corrected article last year, because this error led to an overestimation of the predicted risk. However, even with this correction, other validation cohort found that they found overestimation of the predicted risk with the observed risk. This is the results of a validation cohort, including more than 500 patients, and you can see that there is a shift between the predicted and the observed risk. And the other important thing that they found in this study is that the accuracy of the score was highly dependent of the genetic background. The score really performed well in patients with PKP2 mutation, which is a more frequent gene identified in RVC, but in patients with no mutation identified, or in patients with other genes, such as DSP mutation, the accuracy of the score was really not that good. And you can see that the risk factors was different and between patients with PKP2 mutation and patients with other genes or without any gene identified. So probably the genetic background is very important for risk stratification. Another very important question is the threshold. When you build a score, you want to know at what threshold you should implant an ICD. In instance, for patients with hypertrophic cardiomyopathy, the guidelines say that if your score is above 6%, you should propose an ICD to your patient. But if you apply this threshold to this score in RVC, you can see that more than 90% of the patients have a predicted 5-year score above 5%. And if you look at the threshold of 10%, you see that nearly 80% of the patients have a predicted risk above 10%. Do we want to implant 80% of the patients with an ICD? My answer is no. So this is, I think, one big limit of this score. And you can see on the left figure, that it's only a threshold above 10 to 15% that you begin to have some false negative with the score. Another question is the endpoint used to beat this score is a good one? Because the endpoint that was used was ventricular tachycardia above 100 BPM. But is that a very good surrogate for sudden cardiac death? If you implant an ICD, you want to prevent sudden cardiac death. So maybe you should better focus on the prediction of malignant arrhythmia. So the same team that did the score build another score focusing only on malignant arrhythmia. And you can see that only 4 risk factors was identified, which were the young age, the male sex, the extension of T-wave inversion, but also the PVC burden. And this score was associated with a C-index of 0.7, which is more moderate, and we don't have at this time any external validation to know if we can use this score. The other thought is patients with RVCs, when they have ventricular tachycardia, they can have very well tolerated ventricular tachycardia that can be treated in other ways than implanting an ICD. Here presented the result of a retrospective multicenter study that we performed with other groups present in this room. And this patient with well tolerated monomorphic VT without other risk factors for sudden cardiac death, of course, we found some recurrence of ventricular tachycardia, especially if we only made endocardial-only ablation, but we found no sudden cardiac death in a follow-up of nearly 5 years. Another very important thing is that there may be an impact of the change of risk factor over time. And this is a very important, I think, publication that was provided by the Johns Hopkins group that shows that the risk factor change over time, and that they show a decrease in the PVC burden and the non-sustained VT over time. They found no difference in the morphology or the ECG. And they may due to the impact of medication, maybe ablation, or the sport activity reduction. And what they found is that the impact of this change in risk factor really impacts the accuracy of the score. If you can see that the accuracy of the initial score, which is not corrected, really drops after 2 years of follow-up. But if you correct the score with the actual risk factor during the follow-up, then you maintain a good prediction. And again, as in different cohorts, we found that the initial score was associated with an important overestimation of the predicted risk compared to the observed risk. So some lifestyle modification, especially sport reduction, can have an impact on the risk of your patient. This has been shown in different studies. If the patient decreases his sport activities, the risk of ventricular arrhythmia decrease. And so this is a very important advice to make to our patient. And this is really highlights really different guidelines, especially the recent ESC guidelines, that avoidance of high-intensity exercise is very, very important in a patient with a definite diagnosis of RVC. So we have to acknowledge at this time that the current risk stratification in RVC is really far from perfect, and in my opinion leads to many unnecessary ICD. We need a good multiparametric risk assessment, but at this time this assessment has many limits because we learned that it depends on genetics, so we need to develop gene-specific scores. There is a risk of estimation of the score, and so we have to be very careful when we see a predicted risk of 10 or 20%. Probably it's more than the real risk of the patient. We don't know at this time the threshold that we should apply to the patient, and in my opinion we need to more focus on the risk of malignant arrhythmia and to discuss the place of subcutaneous ICD in young patients in prevention. Thank you very much.
I would like to invite Mr. Sabbag for the next talk on mitral valve prolapse and risk stratification, which I found as really controversial topic.
So should I use this microphone? Or?
Yeah.
Okay. Let me start by thanking the organizing committee for this very kind invitation to talk to you about the risk stratification of patients with mitral valve prolapse. Can I get my slides up? We all know that MVP is very common and generally carries an excellent prognosis, but we've learned in recent years that there is an important subpopulation of patients that do develop malignant arrhythmia and sudden cardiac death, irrespective of their MR severity and even with preserved ejection fractions. We don't know what the prevalence of this newly defined group is. We call them arrhythmic mitral valve prolapse, but we do know that patients that presented once with malignant arrhythmia are highly likely to present with further arrhythmia. Until recently, there was no consensus regarding the definition of this group, but we all agreed on three main components. The first is mitral valve prolapse itself, obviously. The second is mitral annular disjunction. This is an abnormal separation between the insertion site of the posterior mitral leaflet and the left ventricular myocardium. The third component is ventricular arrhythmia. From this large Mayo cohort, we know that some burden of simple ventricular ectopy is very common among patients with MVP, but high burden is less common. Non-sustained VT is even less commonly seen, and sustained arrhythmia, VT or VF, are seen only rarely. So these three components are essential to have the diagnosis. And with the accumulation of data, we thought that it was time to concentrate everything into one consensus document. And I was fortunate to collaborate with colleagues throughout the world to create a consensus definition and suggest a way to risk stratify and manage these patients. Our definition for arrhythmic MVP requires the presence of mitral valve prolapse, with or without mitral annular disjunction, combined with frequent and or complex ventricular ectopy, and very importantly, in the absence of another arrhythmic substrate. So this is, to a great extent, a diagnosis of exclusion. We defined frequent as at least 5% total PVC burden a day, and complex as non-sustained VT, VT, or VF. What do we know about risk markers for sudden death and malignant arrhythmia in these patients? In this systematic review of 161 cases of sudden cardiac death, we can see that about a quarter of the events occur during or soon after exertion. I'm sorry, the markers shifted slightly. So about a quarter of the cases are related to stress. And very importantly, about a third of the events are preceded by syncope. So unexplained syncope is a very important risk marker in this population. Also, this cohort consists mainly of young women, and please notice that we have some events occurring during pregnancy. And in this large registry of pregnancies from the US, you can see that the risk of cardiac arrest among women with MVP was more than 4-fold higher than patients without MVP. So pregnancy is a dangerous period for these young women. Mitral valve repair surgery, we typically think of this as a solution. And indeed, in the Mayo cohort and other publications, a good repair does result often in a decrease in the arrhythmic burden. But there is an important minority of patients that develop de novo ventricular arrhythmia following surgery. So we always need to take that into consideration. Next, we move to the ECG, and we need to look for repolarization abnormalities, T-wave inversions in the infralateral leads as they are associated with arrhythmic risk, and the more leads that are involved with these changes, the higher the risk. Prolonged QT and fragmented QRS have also been linked in small studies to a higher risk of ventricular arrhythmia. The next stage will be to harness artificial intelligence to analyze raw ECG data to give us even better estimations, and this is an ongoing field of research. No publications yet, but there are work in the making. Probably the most important risk marker is the documented arrhythmia. The arrhythmia we capture by using Holter. And in this large cohort from the Mayo Clinic, the burden and complexity of ventricular arrhythmia strongly correlated with survival and with the occurrence of ventricular arrhythmia. Sometimes a simple Holter is not enough, and we need more prolonged ECG monitoring, and an ILR may be an excellent solution. This is a first attempt to use that. A small cohort from the Oslo group, 60 intermediately high-risk patients, and over the follow-up, they found an annual rate of 4% of malignant arrhythmic events. So in a carefully selected population, this can be a very useful tool. Echo is obviously extremely important. The presence of mitral annular disjunction and severe myxomatous changes are both very strongly and independently associated with ventricular arrhythmia, as is left ventricular dysfunction, LV dilatation, and MR. The presence of MVP and mitral annular disjunction distort the function of the myocardium, mainly the basal part, and we can demonstrate that by using tissue Doppler, measuring this sharp spike on the lateral annulus, and it's called the Pickelhaube sign. If you use speckle tracking, we can see dysynchronous activity. And in the most recent publication, if we use tissue Doppler on the lateral aspect of the mitral annulus, we can see this bizarre double peak tissue Doppler pattern indicating this abnormal movement that is sometimes called curling. All of these indicate the distortion of the mechanical activity that is linked to a higher risk of ventricular arrhythmia. Somehow I jumped to the beginning, sorry. Mitral annular disjunction is important, but should not be overemphasized. It is a very common finding. We can see it in about 1/3 of patients with MVP and about 2/3 of the patients with the myxomatous variant. It is, in fact, associated with arrhythmia, but in this largest cohort from the Mayo Clinic, it was not associated with increased mortality. Now, adding to the confusion is the fact that if we use CT on MRI to look at the entire circumference of the mitral annulus in unselected individuals, you can find segments of MVP in almost every patient, making this actually a normal finding. But if you focus specifically on the infralateral region, mitral annular disjunction in that area is uncommon and is associated with systolic curling, MVP, fibrosis, and ventricular arrhythmia. So we should no longer talk about MUD in general, but rather focus on infralateral MUD, as this is the region that is associated with ventricular arrhythmia. I've mentioned that there is an association between exercise and sudden cardiac death, and there is good evidence to show a link between arrhythmia induced by an exercise stress test particularly during the recovery phase, even in patients with normal heart, with all-cause mortality and cardiac death. Now, there are no published data specifically in patients with MVP. This is something that has been studied but not published yet. But we believe that this is important. And like Daniel showed, I also have a very similar patient that was an avid athlete. And when I put him on the treadmill, there was very ugly-looking polymorphic non-sustained VTs. So he wanted to keep running, and so we gave him an ICD. MRI, also very important. We know that late gadolinium enhancement is predictive of adverse outcome, including arrhythmia. But like MAD, also should not be overemphasized. It is a common finding. We can see it in about 30% of all patients with MVP. The prevalence of late GAD increases with the severity of MR. And so if we see a patient with very little MR and a lot of LGE, that is important. That may have a stronger discriminatory power to identify a high-risk patient. What about programmed ventricular stimulation? The initial experience was very disappointing, a very low rate of induction of sustained monomorphic VT. VF was induced, but I think it's hard to interpret that outcome. But more recently, in the last 2 years, Frank Bogan's group and also the group from Mayo, focusing specifically on patients with MAD, were able to induce monomorphic VT and successfully ablate it. And so if we choose the patient's population correctly, if we focus on patients with MVP, maybe we can use program STIM as a tool for risk stratification. Coming back to the consensus document and our approach to the patient, we suggest actively screening all patients with MVP for the arrhythmic variant, using a careful clinical history taking and performing at least a single Holter in a lifetime. Obviously, some patients need more than that, but that is, we think, the minimum. If we document enough arrhythmia in a patient with MVP, then we have a suspected diagnosis of arrhythmic MVP. These patients should be referred to a more comprehensive and detailed echo directed at looking at the morphology of the leaflets, identifying MAD and all the other features that are not part of the standard protocol. MRI should be used in selected individuals, certainly in those who have sustained a malignant arrhythmic event, those where the echo does not give us the data that we need, but also in high-risk patients with unexplained syncope or non-sustained VT. I've mentioned that there is sometimes a need to repeat the evaluation. There are some preliminary data showing that arrhythmic MVP is a progressive condition. The arrhythmogenic substrate progresses over time and also the clinical picture. And so it makes sense to reevaluate the patients over time. And I'll talk a little more about when to do that. I've mentioned the possible importance of an exercise stress test. We think it can be useful, particularly in documenting adrenergic-dependent arrhythmia. Who should get an ICD? That's the billion-dollar question. So obviously, if we consider arrhythmic mitral valve prolapse as a structural heart disease, and I think that is the right approach, these patients should comply with the general guidelines for sudden cardiac death prevention for both secondary and primary prevention. In the consensus document, we added 3 more statements. We thought that it would be reasonable to implant an ICD in a patient with unexplained syncope and sustained, even stable VT, or non-sustained VT, as long as these arrhythmia seem to arise from the mitral apparatus, and also patients with arrhythmic mitral valve prolapse, unexplained syncope or non-sustained VT, and 2 or more phenotypical risk markers. And these are T-wave inversions in the infralateral leads, polymorphic PVCs, mitral annular disjunction, severe myxomatous changes, LV dysfunction, and LGE. To summarize these things, we have this flowchart that starts with the clinical presentation. If our patient just survived an event of aborted sudden cardiac death, of course, he should get an ICD. Otherwise, we should try and document VT. If we do capture high-risk VT, meaning sustained arrhythmia or fast VT, the patient, again, may be eligible for an ICD. Otherwise, an ILR is probably a good option. All other patients should be followed periodically. How often? We decide based on the presence and number of these phenotypical risk factors. If none are present, we're dealing with a relatively low-risk patient that can be seen infrequently. If there are multiple phenotypical risk markers, these patients need more careful follow-up and maybe, again, an ILR. We have to admit that there are major gaps in our knowledge and understanding at this point. We don't really know what is the incidence of sudden cardiac death in the various arrhythmic mitral valve prolapse profiles. I've listed multiple risk predictors, but they all need to be validated. We may need to look for new ones. We need to understand the process of disease progression to understand its predictors and rate. And we need to evaluate the suggested screening and risk stratification program that has been suggested, and the same goes for the suggested interventions. To summarize, arrhythmic mitral valve prolapse is an important etiology of sudden cardiac death. Several risk markers have been identified, and a structured risk stratification approach has been suggested. EP study may be potentially useful, particularly in patients with mitral annular disjunction, and of course, further research is warranted. Thank you.
So we'll switch for the next presenter without the discussion at the end. So it's my pleasure to introduce Professor Michele Brignole. We'll talk about risk stratification in hypertrophic cardiomyopathy.
Okay, thank you. The decision to implant an ICD in patients with inherited cardiac disease is probably the most challenging, or one of the most challenging tasks for electrophysiologists, because inevitably many ICD are implanted without need. The efficacy is low. And on the other hand, the rate of adverse event is very high. For example, either an appropriate shock or complication occur in this survey in 35% of the patients. And if a patient replaces ICD frequently, it is almost certain, 100% sure, that patient will have a complication after 4 ICDs. The good news is that the temporal trend of sudden cardiac death is decreased in the last 20 years, for 0.73% to 0.32% in recent years. Probably this decrease is due to the development of risk score and the new guideline, American and European guideline. For example, the sudden cardiac death risk of at 5 years of the European Society of Cardiology include 7 items: age, left ventricular thickness, left atrial size, the maximum left ventricular outflow tract gradient, family history of sudden cardiac death, non-sustained VT, and experienced syncope. And according to the recommendation of the guideline are that an ICD implantation should be considered in patients with an estimated 5-year risk of sudden death more of 6%, and may be considered with a risk between 4 and 6. Not indicated in patients with a 5-year risk less than 4. As you can see, it is relatively easy. It is relatively easy to assign a score to the first 6 items: age, These are numbers, age, the thickness, left heart age, and so on. The critical point is the last one, syncope, because it's defined as unexplained. What means unexplained syncope? I think that everybody of you have a different definition of unexplained syncope. It depends how much it is investigated. Let me make an example. Imagine a patient who have an age of 30 years, a left ventricular thickness of 20, left atrial size of 50, no gradient, no history of static cardiac death, no sustained VT. If the patient has syncope, the score is 6.59. This means class 2A indication for ICD. If you say no syncope, there is 3.27. This means no ICD. So everything, or most of the decisions depend from an adjective, unexplained. And unexplained is not defined in the guideline. For example, the 2015 ESC guideline of hypertrophic cardiomyopathy, unexplained non-vasovagal syncope. What means? I do not understand what means. The 20 AHICC, syncope suspected by clinical history to be arrhythmic. 2017, syncope for which a cause is undetermined after an initial evaluation. For this reason, a few years ago, we performed a systematic review meta-analysis of article that consider syncope as a clinical characteristics. We collected more than 22,000 HCM patients from 6 studies. Syncope accounted for 17.7% of these patients. We were astonished seeing that syncope was defined unexplained by this author in 85% of cases. So, in practice, any syncope in a patient with hypertrophic cardiomyopathy is defined as unexplained. I suspect that the same occurs for a right ventricular dysplasia and for mitral valve prolapse that have been just discussed. On the other hand, syncope has a mild, moderate risk factor. Indeed, in these 14 studies that consider the outcome of these patients, the patient had a history of syncope had 7.7 risk at 5 years to have an arrhythmic event versus only 3.6. And this risk was confirmed by the meta-analysis where the odds ratio is 2. So a patient with syncope, as defined in those studies, carried a double risk of a cardiac event compared to patients without syncope. For this reason, we decided to perform a consensus in Florence last year. The panel was very authoritative because it was a mix of experts in HCM and experts in syncope, as it included the 4 chairmen of the American European guidelines on syncope and HCM, and many, many members of these guidelines. And what this panel concluded was this algorithm. In patients who have HCM and syncope, first perform a history physical examination, including standing blood pressure measurement, electrocardiogram, echo, and 48-hour ambulatory Holter monitoring. If with this initial evaluation. An arrhythmia is documented. The diagnosis is established, treat the arrhythmia. If it is an AV block, it's an AV block. It is an atrial fibrillation. If it is a ventricular tachycardia, implant an ECD. If no arrhythmia is documented, the second step is to calculate the severity of the gradient of the outflow tracts. If there is a gradient more than 50 millimeters of mercury, treat the gradient. If not, try to confirm, to establish, or to exclude that the cause of syncope is a reflex syncope, because reflex syncope is the most probable cause of syncope. How? But the problem remains always the same. How to define reflex syncope? Guidelines of syncope are of help, but should be applied. There are cases in which the diagnosis is established just by history. For example, vasovagal syncope is highly probable. Is syncope precipitated by pain or fear or standing, and is associated with typical progressive prodrome, pallor, sweating, nausea. This means that a class 1 diagnosis by history of vasovagal syncope requires two factors. The trigger, pain, fear, standing, and the activation of autonomic system, pallor, sweating, and nausea. If there are these two factors, this is vasovagal syncope, and so on. Of course, in many cases, history in its evaluation is unable to establish a diagnosis, and the diagnosis still remains unexplained. For example, there are clinical factors that suggest a reflex, but are not enough strong to establish a diagnosis. A long history of recurrent syncope. After unpleasant sight, sound, smell, or pain, prolonged standing, and so on. In these cases, the investigation should go ahead and include the test. And the tests are 24-hour ABPM, home blood pressure monitoring and wearable blood pressure monitors, and tilt-table test for the hypotensive phenotype, and carotid cell massage, tilt-table test, and prolonged HCG monitoring for the bradycardia phenotype. Here are some examples of diagnostic value. Constitutional hypotension, syncope due to constitutional hypotension, can be simply diagnosed if the 24-hour BPM show a mean 24-hour systolic blood pressure less than 105 millimeter in males and less than 98 millimeter mercury in females. Or if there is with daytime ABPM less than 115 and less than 105. Or if there is a drug-related persistent hypotension that show that each patient have a systolic blood pressure less than 110 millimeter mercury. Intermittent hypotension can diagnosed again by ambulatory blood pressure monitoring when there is one episode daytime systolic blood pressure less than 90 millimeter mercury, or two episodes less than 100. With ambulatory blood pressure monitor, wearable blood pressure monitor, if there is a correlation between low blood pressure and symptoms. With tilt-table test, if there is the typical hemodynamic pattern of hypotension and bradycardia without an asystole. Or during carotid cell massage, reproduction of spontaneous syncope with a follow systolic blood pressure more than 50 millimeter mercury or below 85 millimeter mercury. Bradycardia phenotype, on the other hand, can be diagnosed again by tilt-table test with the typical electrocardiographic pattern of hypotension bradycardia with a systole of 3 seconds, by carotid side massage, by wearable by prolonged electrocardiographic monitoring, wearable and implantable loop recorder that show an asystole more than a syncope assystole more than 3 seconds or an asymptomatic asystole repose more than 6 seconds. Some word regarding loop recorder. Loop recorder has been implanted in patient with inherited disease. And in 91.8% of cases, no ventricular arrhythmias was detected. So these patients were implanted a loop recorder in the suspicion of ventricular arrhythmias, and this was not the case. Atrial tachyarrhythmia 7.1%, advanced AV block 1.5%, reflex bradycardia 6%, non-arrhythmic event 40%, no event 36%. Ventricular arrhythmia was documented only in 8% of these patients. Torsade de pointe 3%, bidirectional ventricular tachycardia 0.5%. So, my advice is the advice of the panel of the expert consensus, is that in HEM, but let me, excuse me if I expand this advice to any inherited disease, consider referral to heart team, including an expert in hypertrophic cardiomyopathy and an expert in syncope. Nobody is so skilled, nobody is expert in both situations. And consider a loop recorder or an ACD when the diagnosis remains unexplained. So, to summarize, the key points. HM risk calculator is useful, as well as the HM syncope algorithm for diagnosis of reflex syncope or unexplained syncope. Bear in mind that the vast majority of unexplained or so-called unexplained syncope are actually benign reflex syncope. Thank you.
Thank you very much. So we it's my pleasure to introduce the next speaker, who is my co-chair, Dr. Krebsová from Prague, that will have the hard task to treat risk stratification in all channelopathies. So good luck.
Thank you very much for the introduction. It's a great honor to give a talk here on this outstanding session, but after preceding outstanding talks, I have to apologize because I'm not presenting my own data. I just mostly stick on the recommendations of the recent guidelines on ventricular tachycardia. So maybe to some of you, my talk is going to be boring and not really bringing new aspects. So I'm going to talk about the long QT syndrome, number or type 1, 2, or 3, and long QT type 7. I'm going to mention Brugada syndrome, early repolarization syndrome, catecholaminergic polymorphic ventricular tachycardia, and risk stratification in short QT syndrome. And as I already told you, I'm going to stick mainly on the recommendations of recent, really very nice guidelines. First of all, long QT, as you all probably know, it's characterized by a QTc prolongation over 480 milliseconds or a genetic diagnosis of a pathogenic or likely pathogenic mutation in all known genes which are known to cause the disease, but there are up to 17 types of long QT, but as you all know, most frequent ones are the first 3 types. Sometimes the diagnosis is not as straightforward, and a long QT diagnosis score might be helpful in some individuals. The risk stratification long QT, we all know that especially women with the long QT type 2 have especially high risk of malignant arrhythmia during pregnancy or in the first year after postpartum, after delivery. Out of this known risk, of course, all patients after cardiac arrest or with documented VT or arrhythmic syncope should have a very high risk of recurrency and have to receive ICD. Otherwise, recently, the group in Italy developed a risk score similar to risk score in RVC or HCM, where we may, especially for the genotype patients for first, second, and third type of long QT, where we may see that or calculate the higher risk and think about the ICD. This risk stratification model was published in 2020 and is based on the prospective observation of over 1,000 genotype patients with a definite diagnosis of LQT. And the authors postulated that the ICD implantation should be recommended in all who have 5% and more risk of arrhythmia in a 5-year. So certainly it's quite a recent development, and we have to wait for prospective data just to assure that it's right and that we do not overestimate or underestimate the risk, I believe. What, as a cardiogeneticist, I recently was really fascinated with the work which was published by Carlo Papone and co-workers about the successful right epicardial ablation of patients with long QT who are symptomatic, and he successfully could ablate on epicardial tissue. And for me, it's interesting, this idea of epicardial cardiomyopathy, which is he talking about in cases of patients not only with RVC, but as well patients with Brugada syndrome, and probably as well with long QT, because all of them are mainly ablated in this epicardial tissue over the RVOT. So certainly for the future, interesting aspect and possibility to reduce the risk of malignant arrhythmia in those patients. Maybe it could be as well the alternative for left cardiac sympathetic denervation, or who knows. Anderson-Tawil syndrome is a long QT type 7, somehow considered as more and more as a separate condition because of its multi-organ or syndromous character phenotype. Of course, as well, all the patients who suffered from cardiac arrest or arrhythmic syncope are there should be the ICD for high risk of recurrency of this malignant arrhythmia implanted. As well, the ICD should be as well considered to be implanted in patients with arrhythmic syncope. But as in the preceding talk, it was really interesting and really very good to recognize how sometimes complicated it is to assess whether it was really arrhythmic syncope. And most of the syncopes, probably, I have to admit, are rather unexplained than clearly arrhythmic. So it is so. Let me proceed to Brugada syndrome. Brugada syndrome is very, in my eyes, very controversial, but probably in some patients, highly malignant condition, inherited. You all know its definition, that there are some, there has to be a J point elevation in right precordial leads, and you have to position there in the second or third intercostal spaces. So if you even in the normal leads, you have a suspicion that there could be a brugada, you do not hesitate to place the leads into the higher intercostal spaces. Of course, the type 1 brugada can be induced through administration of sodium blockers during an Eichmann test, which we have to use as a diagnostic tool in patients with maybe idiopathic ventricular fibrillation or tachycardia. But we know that the provocation or the appearance of brugada type 1 after provocation fever or Eichmann test, it's probably not as specific. It's seen in 2 to 4% of population with, and it's probably unspecific, and one have to think about brugada in these patients only in cases which have another diagnostic or clinical features as malignant arrhythmias, or in first-degree relatives, which I'm dealing a lot in my cardiogenetic ambulance with. Brugada risk stratification is in all of the syndromes. All patients with who are cardiac arrest survivors or documented ventricular tachycardia should receive an ICD. It should be as well offered to patients who have suffered from arrhythmic syncope. And what's as well very important that in patients or in relatives with Brugada syndrome, documented Brugada syndrome, there is a certain role for programmed ventricular stimulation where it is considered to be positive after or inducing ventricular fibrillation after up to 2 extra stimuli. So, but sometimes it's as well not as easy in the praxis, but what is as well very important, there are studies who are not really in the guidelines, but are considered to be additional risk factors. And first of all, it's presence of SCN5A pathogenic mutation, which we find in less than 20% of patients with documented Brugada. Probably as well male sex is the condition which could be a risk factor for malignant arrhythmia. And as well, patients who have not only Brugada type morphology, but as well early repolarization pattern could be at higher risk of arrhythmia. And the same applies to patients who have QRS fragmentation on ECG. So all of these could be taken as additional risk factors if we think about implanting ICD or event recorder in rather asymptomatic patients or first-degree relatives of our patients. Early repolarization syndrome. The diagnosis or early repolarization is a very frequent pattern in general population, but the diagnosis should be stated in patients after cardiac arrest or with documented not really well tolerated ventricular arrhythmia. And there are as well some risk factors for more arrhythmia in these patients, especially if the if the J wave is hardened to 2 millimeters, and it's associated with a horizontal or descending ST segment. And of course, all first-degree relatives of patients with arrhythmia and ERS should be considered for clinical evaluation. The risk stratification is in all, there is a high recurrency rate in all who suffered from malignant arrhythmia, and the the event recorder should be considered in those who are asymptomatic but have additional risk factors as these ST segments, a horizontal or descending pattern or rather prominent J point. Catecholaminergic polymorphic ventricular tachycardia. Rare inherited arrhythmic syndrome characterized by the detection or documentation of bidirectional VTs on exertion. Otherwise, the ECG addressed as completely normal and not associated with any structural heart disease. Genetically, it's caused mainly in autosomal dominant type. It's caused by pathogenic mutations in ryanodine receptor gene, and there are as well a few cases of autosomal recessive form with caused by mutation in CASQ2 genes. All patients with manifestation of the disease in a childhood are certainly at a higher risk of malignant arrhythmia, as well all patients who do not receive beta blockers in full dose, and as well all of these who have a complex arrhythmia on exertion, being on full dose of beta blockers, are certainly at high risk of arrhythmia. The ICD implantation again is recommended in all cardiac arrest survivors, together with full dose beta blockers, eventually as well with flecainide. And anyway, all patients with the diagnosis of CPVT or genotype positive for CPVT should have a beta blockers just to reduce their burden on malignant arrhythmia. Short QT. Short QT is a very rare syndrome characterized by a shortening of QTC interval under 320 milliseconds, but in patients after documented arrhythmia, the threshold is a bit higher, about 360 milliseconds. It's rare genetic disease caused by loss of function mutations in genes otherwise known for long QT in KCNH2 and KCNQ1 gene, and as well in a gene SLC4A, which we have one patient with. It's caused by these genes, and it's the syndrome is rather very rare, and it's characterized by a high lethality in any age, and the carriers of the pathogenic mutations may manifest with AFib or sudden cardiac death. Or the risk stratification is in all of the channelopathies. Everybody after cardiac arrest or with documented ventricular tachycardia or arrhythmia should receive an ICD, and the event recorder implantation should be considered in all young patients with definitive diagnosis of SQT. So there are as well gaps in evidence. Of course, they are as well written in guidelines. I will then add as well from my point of view as a cardiogenetics. Of course, there should be a more robust evidence required to support a prophylactic use of ICD on top of medical therapy with beta blockers and gene-specific therapy in LQT patients. There is a gap in evidence that we need more data on the role of left cardiac sympathetic denervation and ICD in high-risk LQT patients, and maybe we need certainly more data on the possibility of epicardia ablation in all these patients. We need to improve the diagnostic criteria and risk stratification for asymptomatic Brugada patients and suspected early repolarization syndrome. Then we need a long-term data on the efficacy of ICD in CPVT. in survivors of cardiac arrest, because somebody says that patients who have adequate shocks, who receive the shocks, may trigger rather more arrhythmia than before. So then there must be more evaluation on the role of endo and epicardial mapping to identify localized structural alterations, potential to cause idiopathic ventricular tachycardia. There were very nice talks in the morning, and certainly as well tomorrow. That's what the session is about. And it's well poorly understood why women are in lower risk than males. And from my point of view, it's as well to evaluate whether the SCN5A mutation carriers, who are the first degree relatives of our patients, and they do not have a phenotype of Brugada. You know, there's a mixed phenotype or overlapping phenotype in the relatives. They may have a AV block, or they have long QT type 3. So we don't know how high their risk in malignant arrhythmia is. Maybe we have to evaluate the role of late potential ECG as a risk stratification, given the newly emerged theory on epicardial cardiomyopathy. And as well, from my point of view, since I'm seeing a lot of families of sudden cardiac death victims, and you know that most of the deaths occur in the night during sleeping, and so there is certainly a role of nocturnal bradycardia in sudden cardiac death, or even arrhythmia, and certainly this is as well something to be evaluated in the future. Thank you very much for your attention.
Thank you very much. So this session is open for discussion. So maybe waiting for the question. I have some, if there's no question on the floor. Maybe I start with Estelle. Nice talk. You mentioned two things, sports, so high intensity sport. In practice, what do you recommend to your patient? How do you just tell them you do not do any sport, or how do you manage that? Because it's not always easy in clinical practice.
So, of course, I avoid high-intensity sport in all patients, competitive sport. I think we all do that. But in patients with, well-treated HRVC and no specific high risk, it's okay for me for moderate sport activity. So less than 3 hours a week of moderate.
Not per day.
Sorry?
Not per day. A week.
No, per week.
And in terms of intensity?
Moderate,
okay.
Low to moderate.
And you mentioned subcutaneous ICD in RVC. We are not doing that, but it's interesting because you mentioned microvoltage or even evolution of ECG over time. And so what is your experience? Are you doing that systematically, and in which kind of patient? And have you seen any change over time?
Yeah, I think it's in young patients, in primary prevention, in patients who do not have severe RVC. Severe right ventricular dysfunction, I think that subcutaneous ICD is definitely an option. We have an experience, it goes well, I think. What I say to the patient is that it is a temporary type of ICD, and that we may change over time, maybe in 10 years, maybe in 20 years. And so I warn the patient that it may be not the last type of ICD, and that we can go to a non-vascular ICD. But if you can save 10 to 20 years in primary prevention in young patients, I think it is good.
Okay, There's a question, Katja.
I would like to follow on that, Estelle. What do you think about EP study in these patients? So if you have a young patient for primary prevention, you can easily induce a monomorphic VT like the case we have seen today. Would you then change your mind because this patient is at risk for monomorphic VT, which is the majority of all arrhythmias documented in this patient, and then you avoid ICD shocks?
Change my mind, because if the patient, it's just a risk of having monomorphic VT, and you can treat them with beta blockers. We really use a lot of flecainide in association with beta blocker, and it works very well. And if the patient have VT, we can go to ablation. So this is my point of view. I don't know if it's the best one, but in very young patient, 20 years, 30 years, maybe we can save some time with subcutaneous ICD.
Is there any other questions? So I guess I have one for Avi. There's something I didn't get in mind, but you mentioned that the risk of patient with mitral valve prolapse was higher and for the woman during pregnancy. How do you handle that? Do you contraindicate pregnancy, and how do you follow them during pregnancy if they are pregnant? How do you deal with that?
So I think if we say that preventing someone from exercising is difficult, and preventing someone who wants to get pregnant from doing that, I don't think it's doable. This is very preliminary data. I've actually collected close to 20 patients, and we are able to show that the risk is higher in pregnancy, but it's very uncommon. These are probably the highest risk patients, and for the vast majority of MVP patients, it's going to be okay. The difficulty is identifying these patients, and if you really fear, then I would give them an ICD. If they really fall into the really high risk population, then they should be protected. I don't think that preventing someone from starting a family is a recommendation you can do. It's not like you don't fear hemodynamic collapse like with a valvular heart disease or cardiomyopathy. Just an event, you give shock and then they continue. So it's better to protect them and allow them to pass the surgery, the pregnancy safely. We follow them closely in a high-risk pregnancy clinic, and also with an EP doctor to accompany the pregnancy. And we have seen events. All the patients had ICDs and survived, but globally there have been reports of loss of pregnancies, but I'm not aware of mortalities of women. But certainly events did occur.
Thank you. Still no questions. So I have one, Professor Brignole. I'm always struggling with risk stratification in HCM, especially in apical hypertrophic cardiomyopathy, primary prevention in apical hypertrophic cardiomyopathy. Do you have some insight on that? Because all the criteria we see and what has been set up by the ESC is not working much for apical HCM.
No, I don't have information on this, in this particular. I am an expert on syncope.
Excuse me, I have as well one more question to you. It was really outstanding talk, and I wonder whether you have some data about the difference between true MID and pseudo-MID, whether there is a difference in their arrhythmogenicity?
I think that if it's pseudo-MAD, then it's just not an issue. Pseudo-MAD, to me, if we mean the same thing, is a misdiagnosis, particularly in MRI, where it's just an optical illusion. What was reported is that in late systole, in the large prolapsing leaflet, the leaflet is pushed against the atria, and it seems as if it inserts higher where it actually is inserting in the usual spot. So pseudo-MAD is non-issue, just a mislabeling of the imaging. Yeah.
Thank you very much. I think for the sake of time, we'll have to finish if there's no burning question. So thank you to all the speakers. It was a great session. And we close this session and wait for the next one. Thomas, I think. Thank you very much.
Good afternoon to everyone. I'm Antonio Frontera, and together with Thomas Deneke, we will introduce and moderate the next session, which is about the future direction, artificial intelligence, and VT management. Thomas, you want to do some comments and introduce
Yeah, thank
next
you,
speaker?
Antonio. I think this will be very, very interesting, and we've discussed this already, that imaging is very important in also risk stratification of patients in regard to the risk of sudden cardiac death, and we will integrate what artificial intelligence can do, and so it'll be exciting. I hope you enjoy it. And we'll start off with Antonio, my co-chairman, to talk about modeling of VT circuits.
Thank you, Thomas. Ladies and gentlemen, good afternoon. In our clinical practice, we use extensively technology to support our decision. Our typical workflow to study ventricular tachycardia and more in general arrhythmias is based on our electroanatomical data and also imaging that we employ to characterize the electrophysiological substrate. We look for late potential, for slow conduction, for fractionated signals. This gives us a picture of the patient in a specific rhythm during the procedure. We then leverage our experience to identify the optimal ablation strategy, trying to anticipate the formation of the new VT circuits despite of the ones that appear during the procedure. Modeling and simulation techniques can assist in tailoring treatment strategies to individual patients. By integrating patient-specific data such as cardiac imaging, EP measure parameters, and genetic information, computational model can predict the response of the ventricle to different ablation strategies. This is possible thanks to the ability of computational model to predict the induction and sustainment of VT circuits that are not mappable during the procedure. In this presentation, we will focus on the challenge of predicting a patient's ventricular tachycardia circuits. Let's start from the description of the VT circuits, the anatomical and functional pathway through which the electrical wavefront rapidly activates the ventricles. A VT circuit is formed by an isthmus, which represents usually the target of our procedures, and the outer loop, the external pathways. The circuits can involve various pathways within the ventricle muscle or scar tissue, resulting from conditions like myocardial infarction, cardiomyopathies, and these abnormalities generate slow conduction corridors that significantly reduce the electrical conduction and provide a substrate for reentering circuits, avoiding a tail interaction. Finally, functional phenomena complete the picture. VT is indeed a dynamic frequency-dependent arrhythmia that can change in pattern, duration, and location over the time. Warning, predicting VT circuits based on a single rhythm cannot capture the full range of dynamic behavior. Each patient heart is unique, with variation in anatomy, electrical properties, and underlying pathology. Electroanatomical data and MRI or CT scans provide us patient-specific information that can be post-processed to quantitatively characterize the EP substrate. As an example, ADAS or in-art music software are capable of reconstructing possible VT channels, while from LAT data we can approximate conduction velocities. In one of our studies, published in Heart Rhythm 2 years ago, we look at these electrical biomarkers in sinus rhythm and during VT. And as you can see, the combination of this information provide a clear substrate characterization with the indication of where the VT isthmus might be. However, this is only a partial view of the patient condition that results from the specific rhythm during which we have performed the EP study. To compensate for this lack of information, we would have performed numerous pacing protocols to estimate patient arrhythmic propensity. To avoid lengthy procedural times, however, we can partially surrogate this information with physical knowledge, encoded by models based on physics first principles. And we have two types of models that we can employ today. Physics-based models that are developed based on fundamental principles, laws, and equations that govern the behavior of a system. And these models capture the underlying physical phenomena, and they offer interpretability since they are based on known physical laws. Machine learning models learn patterns and relationship directly from data, so these often lack of interpretability and require large amount of data for training and validation. In cardiac EP, we need multi-scale that can capture and integrate phenomena occurring at different spatial scales. from the cellular and tissue scale to the whole organ level. At the finest scale, the multi-scale models incorporate the electrical properties and ion channel dynamics of the individual cardiac cells. Multi-scale models help us to gain insights into the complex electrical dynamics of VT, providing the interplay of structural and functional factors. By comparing electrophysiological indicators in sinus, rhythm, and VT, we were able to show that a VT circuit can present functional slow conduction corridors and functional line of block forming the isthmus, generated by head-tail interaction and tissue anisotropy. This has pushed clinical research to look for mapping modalities that can clinically identify the subset for functional phenomena. Specifically, computational model can help in understanding the main characteristic of the VT circuits. Models show how re-entry occurs when there is a unidirectional block in one pathway and simultaneously conduction through another pathway. Once initiated, the length of the re-entrant circuits is key for sustainment. One, slow conduction corridors facilitate the formation and sustain on re-entrant circuits. Circuits can develop in smaller isthmus thanks to the longer time employed covering the outer loop. Finally, along with anatomical obstacles, VT circuits can also exhibit functional slow conduction in lines of block, which are dynamic characteristics. Here you see a functional prolongation of a line of block. Models are not limited to describe the sole electrophysiology. Electroanatomical models, like the ones developed by the High-Art group, are capable of describing the interaction between the electrical activity and its mechanical function during VT. These models will play a similar role of dynamic functional imaging, enriching patient-specific characterization. Professor Trayanova group were the first ones capable of integrating models into clinical practice. By incorporating computational models can predict the impact of scar tissue on electrical conduction and identify areas prone to re-entrant circuits. Their arrhythmic risk assessment, known as VRP protocol, is based on the propensity of the patient-specific model to induce and sustain re-entrant circuits in many different virtual pacing scenarios. Thanks to the modeling and simulation, Trayanova group is also improving in our comprehension the role of infiltrating adipose tissue, in fat, during VT. Using personalized computation hard models and comparing the results from simulation of VT dynamics with measured EP abnormalities during the clinical procedure, they demonstrated that INFAT, rather than SCAR, is a primary driver of arrhythmogenic propensity and is frequently present in critical regions of the VT circuit. Another valuable tool to study VT is provided by machine learning technique. To build a machine learning model, we need to first collect relevant clinical data from various sources, like the electroanatomical mapping, the medical imaging, the wearable devices like Apple Watch. Then we need to identify the most relevant variables of feature from the available dataset. And then we can rely on two approaches. Supervised learning is a type of machine learning where the algorithm is trained using labeled data and is commonly used for tasks like diagnosis, prediction, risk stratification, and another tool which is unsupervised learning, on the other hand, that deals with unlabeled data where the algorithm learns pattern. Wearable devices, like I said before, especially the Apple Watch, have the potential to contribute, I do believe, in the near future to the collection of long-term health data on a large scale. There may be opportunities to integrate more advanced monitoring capabilities and algorithms into such devices in the future. Our research at Humanitas Research Hospital is now based on 3 projects. We are now exporting every electroanatomical maps into MATLAB in collaboration with High-Art of Polytechnic of Milano, and we run numerical simulation based on this data. The aim is to assess the impact of wavefront directionality in the VT induction. We want to see here, you see example pacing from the right in this known VT circuit, because we mapped the VT circuit in this case, is not able to induce any VT, while indeed a wavefront arriving from left side is inducing sustained VT circuits. Here you have indeed the same low voltage area exported on which we run our simulation. And you see, I run now a numerical simulation on this, in this case, pacing from south. There is a VT in use, which is polymorphic. You see different exit and is polymorphic in their morphology. Indeed, when I pace from southeast, the low voltage area is crossed. It gives 1, 2 beat, and then stops. When you pace from east, indeed, the low voltage area is crossed and then is able to induce a monomorphic VT. When you induce from northeast, north, and northwest, indeed, the low voltage area is crossed and no VT is induced. And this is another project, is what I call the ingredients of the cake. I always thought that VT is exactly like a cake. And this is my grandmother, she is 94, and she's preparing for me a cake. And she told me something, there should be an exact amount of sugar, of flour, eggs when you prepare a cake. Otherwise, it won't work. And I do believe that VT is almost the same thing. There should be a 25%, for example, of a healthy tissue where the outer loop can play and run. There should be 55% of border zone, 30% of scar, which constitutes the line of block and boundaries. And if one of these components are less by only 5%, the cake cannot be made. And so we are now exploring what is the percentage of ingredients that constitute the perfect VT. Another project is about the role of ATP in the VT circuit. How often we see in our clinical practice some ATP that works and other that don't. Is the length from the pacing site, the distance from the pacing site to the VT circuits, is the pacing rate better a burst? So here you see just 1 second of the VT second, and at some point this is the VT circuit, and here you see there is the ATP stimuli, and which enters in the VT, it just penetrates and reset, maybe with the risk of acceleration. Indeed, here you see another second of the same VT circuit, and you see here ATP stimuli that enters and create an interruption of the circuit by head-tail interaction. So in conclusion, modeling and simulation provide valuable tools for understanding the underlying mechanism of VT, optimizing treatment strategies, and guiding therapeutic intervention. These approaches have the potential to enhance personalized medicine, improve patient outcome, and reduce the burden of arrhythmia-related complications. The field of cardiac electrophysiology is actively exploring these techniques, and the ongoing research aims to refine and validate the use of simulation for predicting patient-specific VT circuits. It is our responsibility to support their development, providing clinical feedbacks based on our experience, and to understand how to integrate them in our clinical practice in the near future. Thanks to all the high art team of Politecnico Milano.
Thank you, Antonio, for this very impressive presentation. So we'll move on to the next presentation from Natalia Trayanova from Baltimore. And this is a really interesting question. What differentiates arrhythmogenic from non-arrhythmogenic myocardial scar? Let us know.
I'm looking for, yes. Thank you very much. Can we have the slides, please?
Almost.
Almost. Thank you. Thank you all very much for being here, and thank you very much for inviting me. It's really a pleasure for me to be here. My talk will be a little bit different. A disclaimer, I am not an MD, I'm an engineer. So, although I speak good clinic. So, what I want to talk to you today is, of course, the title that's given to me, what differentiates arrhythmogenic versus non-arrhythmogenic? Well, I have no idea. I don't know. Do you? So what I thought, maybe I will ask ChatGPT. So I did. So I said, what differentiates arrhythmogenic from non-arrhythmogenic scar? ChatGPT answered instantaneously. Scar size, scar location, heterogeneity of scar tissue, scar border zone. I did not edit that. That's straight from ChatGPT. The conclusion, though, was that the arrhythmogenic potential of a scar depends on combinations of things, and particularly a comprehensive evaluation is necessary. So how do we do this comprehensive evaluation? We wanted to do a deep learning for prediction of risk of arrhythmias. How can we use that to predict which scar is arrhythmogenic and which not? So what we did is we created this approach, which we termed very conveniently SCAR, which is Survival Study of Cardiac Arrhythmia Risk. It is an artificial intelligence approach. What it does is it combines deep learning on CMR images and also on clinical covariates, and we wanted to predict what is the risk of sudden cardiac death in these patients. And what we noticed, first of all, we didn't want to segment these images and provide them to the algorithm for two reasons. One, we will be bored doing that. And number two, any segmentation that you make a decision what is the thresholding, you introduce bias. So your deep learning algorithm will learn that bias. So we decided to go, for the first time ever, with deep learning on raw clinical images. We provide the pixel intensity and then let the algorithm learn about the scar and its arrhythmogenic propensity. We also combine that with the clinical covariates. This is a different neural network, and we combined all that in a survival analysis. So you have a deep learning embedded in survival analysis, and we are able to predict the individual probability of the patient of having sudden cardiac risk, a sudden risk of sudden cardiac death, time to death over 10 years. 10 years. So we create these patient individualized survival curves. And what's interesting in the approach is that it also carries the uncertainty in the prediction. We know how certain we are. So we are not saying you have a risk, you don't. We are predicting time to event, and also we know what's the uncertainty. So we did develop that, and here is our patient population. We started with an internal cohort at Hopkins, which consisted of 156 patients from hospitals in Maryland and Delaware. These are patients with ischemic cardiomyopathy, and all of them were at high risk, and all of them received defibrillators. Now, we are blind to any outcome. So this is the internal cohort. We trained our algorithm on that, and then to demonstrate generalization, we used an external cohort to validate it. And the external cohort is actually from the predetermined study with Christine Albert as the PI. And so those are different patients, different group. They were all at medium risk. They did not have defibrillators. So, and the scans were collected from 60 hospitals in the US. We did not exclude any clinical scan whatsoever. So we developed on this and tested on both of them. So here are the results for the performance of this sort of scar-based predictor. So this is the receiver operating curve. You can see the very high performance, actually, and the precision recall curve. Now, this is the internal development cohort. This is the external validation. You can say, well, maybe that's not as high. This is over a period of 10 years. Not year one, not year two, not year two. It's overall performance over 10 years. To have such a high receiver operating value for the receiver operating curve for 10 years, it tells you that the algorithm is learning really well from the data and is able to predict. Let me show you an example prediction. For instance, here we have one patient that had an event and one that didn't. And so this is the actual time where the event occurred. And you can see this is our predictor. We were the closest to the time when the event occurred compared to the other predictors. And here is a patient who did not have an event, and our probability of not having an event was the highest. So that's an example. I wanted to also show you a case in which we had a really good prediction. You can see here, I told you that the predictor carries in itself uncertainty in the prediction. So here, it is quite certain, and that's the actual predicted time of sudden death, and that's our predicted time, very close, and it's pretty good distribution. This is a flat distribution, not as good. So this is one of the worst performing patients. You can see predicted and actual death occurring, there was a difference. So you can see how for each patient we create these individualized curves. So this is the performance breakdown. This might be a little complicated. What I want you to only look is the better the predictor, the higher the blue. And you can see here how our predictor has the highest blue histograms, and also the other is the integrated Braille score. It has to be the lowest, and that's indeed the case. This is a breakdown of the two branches of the neural network system. So this is only the covariates and only the images, and that's the combination of them. So you can see it performs better when you combine the two branches of the neural networks. So then we wanted to see, so what is it learning? And this goes back to the question, what's a rhythmogenic scar, right? So here you can see two patients, and this is an example of what we call developing an interpretable output. So we try to understand what's under the hood of this neural network. So on the clinical covariates, we had the top and bottom four most important covariates, but let's focus here on the images. Those are heat maps that show regions important in making the predictions. So this one is a patient who had scar, but didn't have, of course they all had scar, but didn't have any risk of sudden cardiac death. So the neural network did not pick anything from here. This is a patient who we predicted will have an event, had an event, and you can see here, this is the infarct. It picked some of that, but picked other areas. So it is not really a scar co-localizer. The neural network does not pick only the scar. It is a combination of the location of the scar with the geometry of the heart and so forth. So you can see here that makes a decision that is not simple. If we go back and look at the performance, I want to highlight something here. In the clinical covariates, we have all the CMR data as well. So this is from the radiology report. You have all the CMR data here, and this is the CMR data plus the images. So you can see that the neural network picks additional information from the images that is not contained within the radiology report. So why we think this is a pretty awesome approach? Because it offers a prediction of probabilities up to 10 years ahead and really fully utilizes the pattern of scar distributions. For full disclosure, this is not the presentation that I intended to have. This is my old presentation. The new one didn't get loaded. I have a little bit more breaking down of the important parameters. But what I want to really emphasize is that there are other features of the scar distribution that we just do not know, that we cannot evaluate. So this is the paper where we published that last year, and we have a little sort of cover here with the neural network. What I want to point out, when do you know when a study is successful? Is the first author of this paper, which was my graduate student, got hired to be the vice president for data science in Goldman Sachs. So he went straight from the PhD with this paper to being the vice president for data science in a multinational financial company. So hopefully, you know, hopefully electrophysiology is giving something to the world. Can we apply that to non-ischemic cardiomyopathy? So we did that. It's unpublished. We presented it at HRS. And HCM, we heard about HCM patients. So can we have these scar distributions in HCM also as predictor? This is again unpublished. We are working on that, but it is a cohort of patients at Hopkins, 819 patients we have. So we have the LGs, electronic health records, pretty extensive EHR data, demographics, medical records, ECGs, echocardiogram, LG MRI. All that is our data, and then we combine that in these two branches. This is the image branch, learning the scar distribution here, and then we have the electronic health records branch, and we combine them in a pretty sophisticated way to predict the risk of sudden cardiac death in these patients. So I want to show you the prediction of these two separate branches. This is the image, and this is the electronic health records in these HCM patients, and the shaded area is 95% confidence intervals. But what is important here is the green is the combined predictor, the multimodality predictor. So it has higher predictive capability. It also, in this case, the electronic health records include clinical covariates from the radiology reports, but you can see when the imaging branch learns something additional, so we have a very high predictive capability for that. Now, here is again the same plot, and we compared it for the same patients. Their risk was assessed using the ESC calculator and the American Heart Association calculator. So for the same cohort of patients, this was sensitivity, specificity, accuracy, and receiver area under the receiver operator curve. You can see here our image branch, our EHI branch, and our combined capability, which is much higher than the ESC or the AHA guideline calculators. Now, here we changed the predictor to the same sensitivity of AHA guidelines or the same sensitivity as the ESC guidelines, and you can see the specificity went high up. So it's a very powerful predictor that has really high accuracy in these patients. And again, a very important component is learning from these images. So what we learned from this part to here is that this multimodality information, the fusion, can provide very accurate arrhythmia risk prediction, actually sometimes for really long periods of time. But the most important part is that we are doing deep learning on raw clinical images. We are not thresholding, we are not segmenting. All the pixel information is provided there to be taken into account by the analysis. And it outperformed all the other clinical risk predictors. So the question is, well, what we learned is we can do that in ischemic cardiomyopathy, we can do it in non-ischemic, we are working on ARVC as well. We have a grant that we received on cardiac sarcoid. We are also incorporating additional branch that has the time series, the ECGs as well, because that can be predictive. So we hope that with the development of these sort of predictive capabilities, we'll have better management for our patients. The important component is the learning on the raw clinical images. Now, to go back to the question, what is arrhythmogenic? In a way, Antonio already mentioned that the scar is not necessarily the only perpetrator of arrhythmia. As we have learned recently, also again, and you heard about that today, fat penetrates, that we have adipose tissue that penetrates around the area of infarct, and particularly in patients with older infarct, it may contribute to ventricular arrhythmia. But what is that contribution has not been known. So we also attempted to really investigate what is the effect of fat and scar together in setting the stage for arrhythmia propensity. And this was a really interesting study that we did. We did a prospective study. It's a combined clinical and computational prospective study. So we basically enrolled patients. That's the paper was published in the fall of 22, and that's another image. This is the fat in the penetration is in this patient. Antonio showed that it was, again, we enrolled patients. It was a study also at UPenn and at Hopkins. And for this paper, we had 24 ischemic cardiomyopathy patients. And it is really cute study because the patients received both CT and LG MRI. And then we were able to generate models, digital twins, actually fully dynamic representation of the effect of penetrating fat and the effect of scar and the hybrid contributions in these virtual hearts, and then study what is happening in these substrates. The patients underwent ablation and they were mapped, and electrophysiological abnormalities, we were able to compare those with what we are predicting in our models and then look into the role of scar and fat in the VTs, where is the isthmus, and so forth. So the first thing we noticed is that fat and scar overlap, but not entirely, from the cohort we had. You can see sort of the combined distribution, and here is one example. You can see, it's a large infarct. This is the scar, but the fat is actually somewhat to the side of it. And when you compare the transmural distributions over the entire cohort, it's actually quite different. The scar had a more endocardial distribution. That's the average of all patients, when the fat was more epicardial. You can see how that will affect the transmural propagation of wavefronts in these patients. So we induced VTs in these hybrid models that had both scar and fat, and you can see we basically represent the activation sequence. This is computational modeling. I just cut a piece of this patient's heart and a piece of this patient's heart just so the circuits are better visualized. And in this particular case, it was a location where there was no scar, actually, but there was a VT. And this is from the electroanatomical maps. Those are the deceleration zones. We superimposed that on our calculated VT circuits. We also superimposed the clinical ablations. And you can see that the predicted arrhythmia location in the model coincides very well with where the clinical electrophysiological abnormalities were. But what's important is there was, as I said, there was no scar in that area. What you see here is the distribution of penetrating fat. So fat in itself, also in combination with scar, can be really arrhythmogenic. In the paper, we also demonstrate that if you have only scar and only fat, the number of induced VTs in the substrates was less, much less than the combined substrate. So the presence of fat adds to what is the distribution of scar, and we need to be cognizant of that. And this is my last point, is we looked at the isthmuses in these models that have both scar and fat, and those are sort of the isthmuses based on the activation sequence. And what we found was, in all cases, pretty much these isthmuses were through these border zones of both scar and infarct. So it's another interesting component to consider. So our findings implicate the penetrating fat as an important contributor and open the door for these unexplored additional therapies. So take-home messages: I believe that deep learning on raw images will be very important in managing arrhythmias, both predicting risk of sudden cardiac death, and we are going to use that in combination with simulations for predicting of ablation targets. But scar is not the only arrhythmogenic substrate, and we should account for that. So this is my talk. Thank you for listening. I want to acknowledge everybody. It's an amazing clinical and imaging and engineering team at Hopkins in the center that I direct, and we are there to try to make innovations and contribute to the well-being of our patients. So thank you very much.
usual, congratulations for your research. It's my pleasure now to introduce Thomas Deneke with the talk, A Digital Twin of the Heart. Please, Thomas.
Yeah, Antonio, thank you very much. And this was a fantastic presentation, Natalia. So I'm definitely not gonna even try to go on with something comparable. But what I want to share with you, I hope, is the experience that we have been doing over the last 2.5 years together with our cooperating partner Siemens in working on establishing a digital twin of the heart, so a personalized physiological model, including, on the one hand, anatomy data from CT and MR, also using models of myocardial fiber activation, cardiac electrophysiology, and in the end, perform virtual simulation to create a model that may allow us to identify VT circuits in a scarred heart on the one hand, and maybe answer some of the question, how can we transform a arrhythmogenic scar into a non-arrhythmogenic scar? And first of all, what we had to learn is, and Germany is very bureaucratic, so we had to go through all kinds of data safety boards and administrators, and it was hard to convince people that actually a cardiac MRI of a specific patient, you said the patient's heart is unique, that almost made us fall, because it's impossible to anonymize this, and we had to share the data with Siemens, and we had to prove somehow that just based on the cardiac MRI you could not pinpoint a patient to this. So it's been a journey. So I'd like to just share you one of the cases and maybe tell you, if I have the pointer somewhere. Doesn't matter. I can also do it here. Thanks. Thank you. So this is the history of the patient. It's a male patient with an MI in 2018, posterior MI. You can see it on the EKG with Q waves in 2, 3, and AVF. And this is the cardiac MRI. And what this does is actually it in this digital twin model, there is an automated segmentation of scar of the left ventricle, of the right ventricle, of the endocardium, of the epicardium. So all of this is done automatically, and it creates a 3D model of the heart with transmural, non-transmural scar with LV, endocardium, and epicardium, and also the RV as a 3D model of the patient's unique heart. In the first part of this process, we also did integrate data from our mapping studies. Then all these patients were VT patients, and so we had data from our ablation procedures, and this was used to implement individualized electrical properties of the heart. And I think this is something that is very important. So from here we move towards a estimation of the individual electrical properties of this specific patient. We're now able to do this from the sinus rhythm EKG, so from the QRS complex. You can see it right here. So this information is used to create the conduction properties of this specific scar and this specific heart, and we can reverse that. And I think that is interesting just to see. So from this information, we can get back to modeling and simulating the activation pattern. So we create a QRS morphology that is, at least in the quantitative analysis, comparable to the sinus rhythm EKG, as you can see here. So it's comparable in QRS duration and QT interval. It does not look like the original QRS complexes in the sinus rhythm EKG, but it's at least in the quantitative analysis pretty comparable. So then what Natalia didn't tell you is that, of course, you can virtual stimulation of the heart, and you can do this from any site in the LV or RV, and by that identify the potential arrhythmogenicity of a specific scar. And in this case, you can see this was a patient before VT ablation, so we hope we could virtually induce a VT, and you can see the activation pattern during virtually induced VT. And we can also modulate the specific three-dimensional activation pattern during this reentrance circuit. As you can see here, in black you can see the scar, and at different times you can see the slow conduction through the isthmuses, and actually thereby identify potential regions, how to modulate this arrhythmogenic scar and turn it into a non-arrhythmogenic scar if you modulate these areas of slow conduction. Again, going back to EKG modeling, it's a little easier with VT because this is more or less like a pacing situation in the heart. So this was the clinical VT that was induced in this patient, and this was the computed 12-lead EKG from the model based again on the pretty much the scar and the 3D three-dimensional visual estimate of the heart, and you can see it at least looks in some parts comparable to the clinical VT. We're still working on that. This is work in progress, but I think at least we're getting towards having a more or less congruence in some, specifically in the extremity leads. So in this specific case, we also did a follow-up MRI 3 months after ablation. Again, this is the automated segmentation through the model. In red, you can now see our ablation lesions in here. And if you look over here, this is the overlay of the late gadolinium enhancement of the initial scar with, in yellow, the ablation lesions. It's hard to see right there, but putting this back into the 3D model, you can now see this was the original scar. This was what we did and what was left from our ablation 3 months after the procedure. And now again, you can do some virtual stimulation and see that we really were able to turn an arrhythmogenic scar by performing ablations into a non-arrhythmogenic scar. So only non-sustained ventricular arrhythmias were induced. This is the initial project, and we hope to, together also with Natalia, whom we have been collaborating on identifying this potential chance to create non-arrhythmogenic scar out of an arrhythmogenic scar. I think it's just interesting to see what we can do all with artificial intelligence and good quality images. And I think that's crucial. We need good images, because if not, whatever comes out of the system is not working. Thank you very much.
Thank you, Thomas. Impressive talk. Congratulations. Very nice. I'm happy now to introduce Dr. Hatala on artificial intelligence and prediction of sudden cardiac death risk. Is all in the ACG.
Good afternoon. Professor Deneke, Professor Frontera, ladies and gentlemen. First of all, I would like to express my gratitude to Professor Joseph Kautzner for inviting me to join
with distinguished faculty. And the task I was assigned is reflection on the role and on the possibilities of standard ECG in predicting the risk of sudden cardiac death. You just heard very futuristic presentations about the possibilities of the new technologies which become a reality. So I will go maybe a little, almost 100 years back to ECG and try to pick up some features which might be useful also in the era of artificial intelligence. Okay, so, well, let's just a short start with the Greek mythology. Sudden cardiac death is certainly very well demonstrated already in these times. And here on this picture, you see a man whose name was Pheidippides. And Pheidippides was a heterodrome. That means today he would be a delivery man. This is the position where Jeff Bezos started, but here he was not so lucky and he died after a long marathon run of, in fact, more than 40. In fact, here he was running more than 100 kilometers. And I show this picture because it very nicely shows that someone who is in perfect shape, who is in perfect condition, dies suddenly. Sorry. So how the unmet need we are now faced with is how should we improve the risk stratification and prediction of sudden cardiac death. Well, this is a very nice diagram from the most recent ESC guidelines, which very clearly show that sudden cardiac death and ventricular arrhythmias are temporarily localized in various periods of life. And certainly we have to take this into account when dealing with personalized risk stratification. And you will see also on this diagram that the volume of cases is certainly very different. Its most common are acute coronary syndromes, followed certainly by chronic coronary artery disease. So how can we achieve this personalized risk prediction? Well, we have also very simple tools. We have to use different approaches at different ages. We should improve our history taking with targeted questions. As we have seen, we have fantastic possibilities for imaging, but we have also many new biomarkers. We have genetic analysis, molecular autopsies. But sudden cardiac death, sudden arrhythmic death, is mostly an electric problem. So we should also look at the electricity, first of all. So ECG is crucial, but until now, we had a relatively poor extraction of information. So analysis by artificial intelligence could be potentially revolutionary. Another problem we have with sudden cardiac death, that when we look very strictly at death registries, then we can see that only about 60% of sudden cardiac deaths are really sudden and cardiac. 40% are neither sudden nor cardiac. This makes certainly the correlations between certain parameters and the outcome very difficult. So artificial intelligence basically aims to characterize relationships among multiple variables on very large data sets. machine learning can certainly yield mainly associations and correlations. It currently cannot make definitive cause-effect inferences. And the principal task we use it is for classification, for prediction, and for discovery. So certainly I'm going to talk only about prediction. Artificial intelligence in cardiology is already used in several applications. We can, for instance, diagnose from 12-lead ECG, aortic valve stenosis, or mitral regurgitation, left ventricular systolic dysfunction, and so on. And we can predict on the basis of sinus rhythms, ECG, atrial fibrillation, and possibly also cardiac arrest, and several other syndromes. This is a recent statement from a very serious consortium of experts telling us that mitigating the risk of extinction from artificial intelligence should be a global priority alongside other societal scale risks such as pandemics and nuclear war. So on the other hand, we know very well that the potential in medicine is huge. Deep learning is basically a technology, a robust artificial intelligent algorithm which can imitate, or which would like to imitate, the data processing patterns of the human brain. As input, you can certainly choose various data sets, for instance here 12-lead ECG and echocardiogram, and then running this information through a convolutional neural network, you on the end of this process arrive to an output, and typically we use for that so-called supervised learning. That means that we feed into the system labeled data. ECG appears as an ideal target for applying artificial intelligence because it's widely available, it's easily stored and transferred, we have huge data sets available, and we have powerful computers available. In the general population, this is relatively very difficult because all over the world we have maybe some 1 to 2 million victims of sudden cardiac death, but certainly the prevalence in the general population is relatively very low, but it changes, of course, dramatically with the age. I believe the future is a kind of integrated approach. That means using biomarkers, using ECG, but at the end, of course, we also need to use, I would say, common clinical wisdoms. Now, ECG parameters which are associated with increased risk of sudden death are quite well known for several decades. This is an example of several parameters which are not very used in clinical practice because looking at them in detail may be quite cumbersome. For instance, QRST angle, left ventricular hypertrophy in the ECG, corrected QT intervals, T-peak, T-max intervals, and delayed QRS transitions. We know about all these parameters that they are somehow related to sudden cardiac death, but the practical use until now was relatively low. This is a paper looking at electrical risk scores beyond left ventricular ejection fraction for predicting sudden cardiac death. And you see that all these parameters which I have just mentioned are added into a single score. The data were taken from the Oregon Sudden Unexpected Death study and from the ARIC study. And the more of these parameters the patient collects, the higher is certainly the odds ratio for sudden cardiac death. Spatial QRST angle is an interesting parameter which was described quite a long time ago. And it's especially interesting to see that an abnormal QRST angle is linked to a almost 5 times higher probability of risk of dying suddenly. Nevertheless, we do not use this parameter in real life. Recently, it was clearly shown that this QRST spatial angle parameter is linked to genetics, is linked to identified foci which start to operate during embryogenesis and which influence the development of the myocardium in the next years. Fragmented QRS is a predictor of mortality, which is well known. All clinicians know very well that these kind of QRS patterns with notchings and slurs. However, they are very variable, and we do not have until now a really high-quality analysis linking these fragmented QRS, notch QRS complexes to the risk of sudden cardiac death. We know quite well that they are, of course, due to collision of wavefronts, mostly around scars on the myocardium, mainly on the epicardium, which is then demonstrated on the surface ECG. Recently, fragmented QRS was used as a predictor for mortality for heart failure with preserved ejection fraction. And you can see that patients with such QRS complexes have an increase roughly between 50 and twice as high hazard ratio for cardiovascular mortality. These are the same data, and they tell us that inferior fragmented QRS complexes are intermediate risk stratifier. Anterior and lateral fragmented QRS complexes mean a very high risk of cardiovascular mortality. Fragmented QRS was also used for risk stratification in Brugada syndrome. And you see on these 4 curves that only fragmented QRS was able to predict syncopes caused by ventricular arrhythmias, in contrary to genetics, late potentials, and programmed electrical stimulation. Certainly, once again, very variable parameter, very difficult to capture clinically. Maybe the new artificial intelligence tools focused on ECG could be helpful. We have developed such a tool and for the moment it is applied for acute obstructive myocardial infarction. So it goes towards definition STEMI, not STEMI non-STEMI, but obstructive non-obstructive, and it delivered a remarkable performance in identifying those patients who have an obstructed coronary artery, even with a non-STEMI myocardial infarction. 40 years ago, a group of Gall and Wagner published in New England a paper looking at the QRS scoring system, which was able to predict left ventricular ejection fraction. This was never used in clinical practice. However, artificial intelligence can capture these feature from the 12-lead ECG electrogram, and to even not only to detect low ejection fraction, but to predict development of decreased ejection fraction in the following years. So this is certainly something which could improve our prevention, our preventative efforts in those patients who are on high risk on such development. this is again the paper and the results, the curves showing that we can identify patients who will, in a time horizon of about 12 to 15 years, develop low ejection fraction with a high probability. QT interval, a measurement of QT interval, clinically also not always very easy, especially because it's a very valuable parameter which comes and vanishes with time in the same patient. And this paper describes the possibility of identifying very precisely QT interval and measuring QT interval only from two leads, two ECG leads. We do not need for this a 12-lead ECG, but only 2 leads, and this would make such a tool very useful for identifying patients with a high risk of long QT. This is another application of artificial intelligence in 42 patients who have recorded monophasic action potentials from the endocardium. And then these monophasic action potentials were analyzed by a deep neural network. And what we see is that it can distinguish those patients who will later develop ventricular tachycardia or ventricular fibrillation. But if you look just by naked eye on these monophasic action potentials, you see that it's very difficult to really see major differences. So this is really something where AI can excel. Toza de Poin, long QT, I have mentioned already this. This is a paper which described the possibility of detecting latent long QT in patients who receive sotalol. Sotalol, in fact, is able to block the delayed potassium rectifier current and identify patients who are prone to long QT by taking drugs or who have a congenital long QT which is not manifested right on a particular ECG. What is important here is to show, and this was already nicely shown by Professor Trayanova, that artificial intelligence becomes not more and more not a black box, that we know more and more which features are really decisive for the algorithm to make this or that decision. So here you see, for instance, the green color corresponds to the areas which are important for these kind of decisions. Again, a cohort of more than 2,000 patients, 80% accurate pregenetic test by looking at 12-lead electrocardiogram and analyzing it by artificial intelligence. Enormous help for screening. We are here on a VT meeting, and this is a relatively recent paper looking at non-invasive localization of post-infarction ventricular tachycardia exit site to guide ablation planning. And this is a combination of computational modeling and real data. And what is important here, that it takes into account not only surface ECG, 12-lead surface ECG. Very frequently, we don't have 12-lead ECG from ventricular tachycardia, but what we have in patients with ICD are intracardiac signals, intracardiac electrograms, and you can combine this information and obtaining a proposal on exit sites and scar location and expected scar volume, which will be relevant for ablation. So artificial intelligence, I believe, heralds a new era for the electrocardiography as such. It is rich on relevant information, which was hidden, undiscovered until now. It allows us to identify both visible and invisible in the standard 12-lead ECG, and there are two important advantages. One is not exactly for this forum, compensate for lack of expertise, which is more for the primary care, but also for detecting early stages of various disease processes. And I think this is what is important here. And it has a potential to diagnose and predict later manifestation of diseases with intermittent phenotypes, and ECG, and use ECG as a biomarker also for cardiac, but also for non-cardiac systemic diseases. And we have several times used the word deep learning, and here I would like to finish also with a little bit of mythological slide, deep learning. Alexander Pope was a very sharp-tongued, sarcastical critic and poet, and in one of his poems he writes, "A little learning is a dangerous thing. Drink deep or taste not the Pierian spring, where shallow draughts intoxicate the brain, and drinking largely sobers us again." So when going to source of knowledge, we should not sip, but we should binge. And in the sense of immersion, this is the responsible behavior. And I think this is a little bit a problem of our world today, that very, very often we remain on the surface and do not go deep enough. And with that, I would like to thank you for your time and attention.
Thank you very much. And as we are running a little late, are there any burning questions? We have some coffee break and we will reconvene at 5, but there may be time for 1 or 2 questions. Robert.
Yeah, I enjoyed very much the presentation for Professor Trayanova, and a philosophical question. It is surprising that we know since the 80s that arrhythmogenic dysplasia is a pathological process which was especially pro-arrhythmogenic, and we knew that it's a combination of fatty and infiltration and fibrosis. And only after almost 40 years we come to similar conclusions, and even more, fat appears to be also very dangerous for the atria, for atrial fibrillation. Could you comment a little bit on that?
Well, I would like to distinguish 2 aspects of adipose tissue. One is the epicardial, and the other is the penetrating. And so ARVC, we have penetration. What I presented today is penetration. The epicardial fat is a little different because it doesn't present an anatomical barrier per se for the propagation, but it affects electrophysiological properties via paracrine effects. So I think it is, these things were not very well appreciated. ARVC is a very stark example of penetrating fat. The other aspects of adipose tissue were not really, and I think ARVC has been an example what could happen, and that's what led us to think maybe there are, other aspects that we are not taking into account. So I think it's very important for rhythmogenesis in any arrhythmias, if not through penetrating, at least through epicardial fat.
Thank you, everyone, for this wonderful session. And I think we'll close and have time for a coffee and reconvene at 5 sharp. Thank you, everyone.
Thank you.